love to start with just a conversation. So why don't we start by going around and doing a little bit of an introduction, providing some local context. Why don't we start with Marge?
Hi, good morning. I'm Marjorie Arca. Actually, I'm currently in upstate New York, so it's not New York or New York City. And our actually, we did a very early social distancing. I think it was the second week of March. On a Sunday, we did quite a bit of social distancing and canceled elective cases, elective clinics. So our community COVID surge has not been bad. We have done a lot of delegating of the ICUs. So for instance, our surgical ICUs have been now dedicated to medical ICUs, our surgical, so cardiac, neurosurgery, trauma burn, and the surgical ICUs have relocated to what would be our pre-anesthetic or preoperative area, and also our PACU. Our acute emergency adult cases are done in one of our affiliate hospitals. So if you have a small bowel obstruction, you go there instead of coming here. All of the sick COVID patients come to the University of Rochester. The Children's Hospital is a tower of the adult ICU. We've elected to keep all the children, thankfully, in our neck of the woods, unlike, say, places like Montreal. We do not have any COVID positive pediatric patients in hospital at this point. So the way that we participate in the adult care is actually determined systematically. We're the line people, the line and procedures people. And so what they've done is they've created a schedule by which surgeons, there's a schedule of surgeons that come for whenever they need procedures. They just have us come in and help at that point. Now that's like phase 2. Phase 3 is obviously different, but we're currently at phase 2, thankfully, at this point.
Thanks, Marge. So at this point, you are involved in the adult patients, but mainly just for procedures, not in primarily managing their critical care. Okay.
Yes.
Meghan, do you want to tell us a little bit what's going on in Michigan?
Sure. So my name is Meghan Arnold. I'm one of the pediatric surgeons and critical care physicians at the University of Michigan. And despite doing some moderate social distancing fairly early within the state, we have seen our COVID surge and are sort of right in the middle of it. And primarily what we've seen at the University of Michigan is a drastic influx of patients from the Detroit area, which is being very heavily hit with very sick COVID patients. So within the University of Michigan, we have expanded our ICU capacity dramatically. So typically we have about 100 ICU beds. Our goal at the end of this is to be able to support as many as 270. So we have expanded all of our current ICUs, both our medical as well as all of our surgical and affiliated surgical ICUs have become now full, or essentially full COVID units. And then in addition, what's really ramped up over the last 2 to 3 weeks is that we've converted an entire floor now of the Children's Hospital. What used to be 64 pediatric single bed rooms now has the capacity to be 100 COVID ICU beds. One of those units is at full capacity of right around 50 patients. And the last one, which is going to be primarily staffed by the pediatric critical care medicine and then the pediatric surgery teams, just opened up this week. Currently has a census of 5 patients. The plan is to get towards sort of 10 to 15 patients by the end of this week. So in that unit, we as the pediatric surgeons are the attendings providing the care. And then I've spent some time in the sister unit with the adult providers, which is primarily the anesthesiologists, who are being the bedside attendings of those patients.
Okay. So it sounds like a little bit more further along compared to in upstate New York, where you're actually already involved in taking care of these patients.
Mhm.
Samir, you're also in Michigan. Do you want to give a little bit more context in terms of how was it decided how that unit, especially the one that's in the pediatric hospital, was going to be staffed? What combination of, pediatric critical care, pediatric anesthesia, pediatric surgery? Are there any adult providers in the midst? How did you guys kind of train and prepare for this?
Yeah, so Samir Gadepalli, also a pediatric surgeon and an intensivist at Michigan, working with Meghan Arnold. So we actually, both of us have been covering the adult ICUs this week, and in the two units that Dr. Arnold mentioned, she has been in the original regional isolation unit that has 50 beds, and then the second unit just opened up this week, and I've been in the new unit. The new unit would be staffed with pediatric intensive care as well as pediatric surgery. Our anesthesiologists have been the airway team for all of the ICUs because, as you can imagine, intubation, extubation are aerosol generating procedures. And so it takes a fair amount of resources and effort to do those. And so they've been available primarily for intubations, but we'll probably talk more about this, but there's definitely differences in terms of adults and extubation rates and reintubation rates. In pediatrics, we've tended to be more conservative about extubations and how parents handle failure of extubation with reintubation is very different than in a COVID unit where unfortunately there's actually no other family members, and there's also a need for ventilators to be freed up. And basically in the adults, we've been very aggressive about getting them off ventilators. And in fact, we've seen almost like a 20% reintubation rate, which means 80% have been successfully extubated in a fairly aggressive manner, where they'll come off to like a high flow of like 50 liters, 50-60% FiO2. The trade-off is like, PPE use and exposure of healthcare workers in the setting of reintubation. And so it's definitely carefully planned, but we're being fairly aggressive about it. So in terms of training for the model of care, all of us have kind of spent some time on the adult unit that is being staffed by pulmonary critical care medicine, CCMU physicians, as well as anesthesia adult. Now that the unit has opened up, it's primarily been staffed by pediatric providers. But now when I say providers, I don't mean just like the attending physicians that you see here, but also we have our PAs being deployed there, NNPs from the NPs from the pediatric medicine side. We have pediatric residents, pediatric hospitalists. We have some of our surgical residents in the adult SICU now. And so we basically focused all of our care in helping develop the ICUs.
Okay, thank you for that. So you mentioned that you had spent some time with some of the adult providers to prepare. Are there a mix of adult and pediatric providers in the unit that's been put up in the pediatric hospital, or is it now solely staffed by the pediatric?
So as of right now, it's solely staffed by the pediatric providers.
And the PAs and the extended care providers you mentioned, those are pediatric trained as well. Are they from the ICU, or are they from the surgical teams? Is it a combination?
Combination. So, for example, the last two nights I've been on with pediatric hospitalists, and they don't have any ICU experience, but they've been able to serve as frontline providers, gathering data, making decisions, so forth, with supervision from ICU physician like myself.
So a couple of weeks ago, we had Dr. Stylianos on from Columbia, and he had shared a kind of a pyramid structure for the hierarchy of how the care is managed in the ICU. Maybe one of you guys can talk a little bit more about that. You mentioned, Samir, that you are supervising people like hospitalists or other frontline providers. How does it work compared to like the normal way that an ICU would be staffed in terms of how many different patients care the kind of top of the pyramid would be supervising?
All the units had very similar structures. So I'll talk about the new unit that we opened up has basically 4 providers as frontline providers, each of which will eventually have up to 12 patients on their teams. So there's 4 teams, and each of those teams have either residents or advanced practice providers as frontline, being hierarchically supervised by a fellow and then a faculty. Dr. Arnold, do you want to talk about the RICU?
Sure. So the RICU is the sort of sister unit. And in that side, again, 4 teams, 2 led by pulmonary, 2 led by either surgery or anesthesia. Each one usually has between 2 and 3 either residents or APPs doing the minute-to-minute management. Usually have 1 fellow divided between the 2 teams, and then each team is led by a faculty member. So a core group of about 4 people. Like Samir has described, that the one unit has been up and running for about 3 weeks, and then the sister unit is just opening, trying to keep the same model. The big difference between the 2 is that in the newest unit is primarily being staffed by pediatric providers, but it's right next door to the main, the RICU, the regional isolation unit. And so there's been a lot of sort of just crosstalk between the 2. I was up there yesterday, and the peds critical care medicine attending came over and just sort of clarified some questions. So there's, I think one of the most amazing things that has come out of this that I hope lasts long term is the kind of can-do attitude that everybody has, and the collaboration and camaraderie that has been generated among people who have never worked together. You know, we have, you know, medical ICU nurses working with anesthesiologists, working with pediatric providers. I mean, the fact that pediatric hospitalists are helping to staff, you know, an ICU of adult exceedingly critically ill patients, I think just sort of speaks to the all hands on deck attitude, and the fact that people have really stepped up to take care of patients that they're not used to taking care of, but with an attitude that, you know, with the appropriate help around them, that they can do it. And I think we, as pediatric surgeons, really have kind of a unique perspective and ability to help, because we did spend so much of our training taking care of critically ill adults. And while we don't, you know, take care of them as much anymore, that we can kind of bridge that gap between the pediatric providers and the adult anesthesiologist and surgical providers. So I think we have a really unique perspective and ability to really step in and fill this need, which right now in the state of Michigan is critical. And what we've seen is that what we are doing is we are offloading the hospitals around Detroit, which are just being absolutely saturated with some of the sickest patients that I have ever taken care of.